ranges up to 5 times the normal levels compared to the disease-modifying agents. Although there is some differences between the different types, infliximab being in the middle, but the risk is really significantly high that you have to strongly consider prophylaxis. And in our area where tuberculosis is really endemic and most of our patients have been exposed, then we have really to take it serious. Sorry. What is the difference between TST and, or the effect of TST and BCG? Most of us question the positive TST, particularly in young people. Is it due to BCG or not? BCG patients who have BCG, they probably will have a positive TST in their early life, usually in the, as children. But above 15 years of age, many studies showed that there is no significant effect of BCG in the positivity of TST. And therefore, if it is positive in these adults, it is due to infection most of the time, particularly if it is strongly positive. Then it's very, very unlikely to be due to BCG. So take the positive TST significantly, regardless of the BCG status of the child. The question in children may be a little bit different, so you may need to pursue doing IGRA in child. The use of IGRA, this is the recommendation from the Saudi recommendation about treatment of latent tuberculosis. They don't recommend IGRA as a routine, but should be considered in certain situations, like if you're questioning the false positive TST, or particularly in children, then you may need to do it. But otherwise, the standard test for latent tuberculosis should be still a tuberculosis skin test. It is cheaper and no much difference. The recommended treatment, again, is isoniazid, either on a daily basis or twice, depending on your hospital. Recent meta-analysis really showed that probably neither IGRA nor TST are predictive of reactivation. This meta-analysis looked into more than 26,000 patients who were followed with positive TST and IGRA collectively, and they found really that they are not good predictors of reactivation. So the question, do we still continue to do them? Of course, the guidelines all recommend that you do them. Huh? That's for the latent. Yeah, we're talking about the latent. They should not be used at all for diagnosis of active TB, except as an adjunct to support your clinical. Okay, so my action would be to do IGRA available. If positive, start chemoprophylaxis. If IGRA is not available, I will repeat TST and start treatment. Definitely if it is above 15 millimeter, but if it is even 10 millimeter or more, I will give her prophylaxis. Case 4 will be very quick. Just 27 years old. Still, how much time I have? 3 minutes more, okay. 27 years old lady, married with 2 children, referred to you because of recurrent UTI. This is, again, a very common outpatient case we see, and unfortunately, recurrent UTIs are poorly managed by GPs and even urologists and nephrologists. We see them suffering for years, and nobody just mentioned or initiated prophylaxis therapy. So recurrent UTI for the past 3 years. She has history of several episodes of dysuria, urgency, and frequency. That's usually treated empirically as a UTI. We don't have definite cultures. She gets about 4 to 5 episodes per year. The last episode was about 1 month ago. Urine culture at that time grew E. coli, sensitive to augmentin, TMPX, cefuroxime, and ciprofloxacin. She was treated with augmentin for 7 days. And then she was referred to you because of this recurrence. And prior to her appointment, she had a urine culture done, which was positive, but she's currently asymptomatic. So she's asymptomatic, and you have a culture from 2-3 days ago, which is growing again, E. coli, but this time it seems to be an ESBL, since it is only sensitive to nitrofurantoin, TMPSMX, amikacin, and meropenem. So what do you do for her? Again, for the sake of time, we'll go quickly about the questions. Since she's asymptomatic, keep her off antibiotics. Follow up regularly with repeated urine culture. Who will go with this culture, with this option? No, she's not pregnant. No, single healthy married lady. Nobody will go. Okay. Treat this episode of asymptomatic bacteriuria and start on prophylaxis. So you want to eradicate the current asymptomatic bacteriuria, then initiate prophylaxis. Who will go with this option? No one? Well, again, for the sake of time, I'm not going to discuss the investigation and the asymptomatic bacteriuria, but just only the question of the treatment. That's basically, but usually you don't need really to investigate because most of them are normal, nothing you will find. Keep her off antibiotics and do urine culture only if she becomes symptomatic, and treat accordingly. For this one, you think? Start her on prophylaxis antibiotics from this visit regardless, and leave her without treating this episode. More hands here for this one. Sorry? With the keep her off antibiotics and do urine culture only if she becomes symptomatic. So you will not depend on the previous history to initiate prophylaxis. Screening for asymptomatic bacteriuria is not recommended, of course, in these categories. In all healthy women or premenopausal or diabetic patients or older person or elderly institutionalized catheterized patients. So basically don't seek asymptomatic bacteriuria except in pregnant women and transplant patients and pre-urological procedures, particularly in males if you want to do prostate or cystoscopy and so on. Otherwise, no screening for asymptomatic bacteriuria. I will skip this. So treat, okay, I will skip this. This is prophylaxis. Again, I'm sure all of you know that chemoprophylaxis is recommended for any patient who have recurrent UTI more than 3 or more per year with once daily dosing, which is the best preventive measure. A recent study questioned actually the need to go and seek and keep repeating cultures in asymptomatic patients even if they have recurrent UTI. So you keep them, okay, I'm concluding. So you keep them on prophylaxis and you don't need to follow. That's basically the recommendation from this study. Although there is a lot of drawbacks in this study, but basically they showed that if you keep following and repeating cultures and adjusting antibiotic prophylaxis based on the culture, if the patient is asymptomatic, it is detrimental. It will lead to more recurrences and more resistance. And therefore they recommend keep the patient in prophylaxis and don't recheck the urine unless the patient is symptomatic. So basically I will, because this study is new and it's only for a special group, they are highly sexually active, most of them patients with STDs, and from single center, I will not take the recommendation of this study as yet. And therefore I would eradicate this episode and initiate this patient in prophylaxis. That's what I will do in my practice for such a lady. Because if you left her, she will come back with symptomatic after some time. Okay, if you want me to go through this case or I conclude. Actually, thank you very much. Thanks.